nivolumab, there was the New England Journal article by Steve Ansell in 2015 looking at, and it's very exciting, it was in Hodgkin lymphoma. Before we go on to discuss that, I think that that was a perfect malignancy to pick. And why? Well, because we have this, you have the PD-L1 that's upregulated, the ligand is upregulated on the actual tumor cell, and you have a very rich inflammatory response with T cells and other cells, B cells and monocytes surrounding the tumor in the microenvironment. And therefore, if you're going to use something as your first chance to see proof of concept, I thought that was brilliant. I really thought that was the best tumor in heme malignancies to choose at the beginning. And I think you had some experience, Yvonne, with the nivolumab. Charles, maybe you can tell us what.
Sure. So I can tell you, I mean, I think retrospectively it was the right disease, but I can tell you that the trial design was lymphoid malignancies.
I see.
And Hodgkin's ended up falling out.
Amazing. Amazing, yes.
So we participated in that trial. You know, there was, Hodgkin's was on the far extreme of therapies that actually worked. You know, I would say myeloma was on the other extreme of a disease for which we got really minimal amounts of efficacy as a single agent therapy. But what I think has happened is again, you know, as you alluded to, PD-1 blockade is one of the revolutionary agents that is now available to Hodgkin's lymphoma, specifically relapse refractory Hodgkin's lymphoma. And I think this has, getting back to the point that was discussed earlier, socioeconomic implications, because this is a disease, for the most part, that of also very young people. And so the potential benefit to society is an important one. Having said that, the response in this disease, at least in this study, was for heavily pretreated patients was, you know, well above 60, close to 70%. And it was a very fast response. And what it has enabled for a lot of these patients, especially the young ones, is to be served as a bridge to get them to allogeneic transplant and potentially to a curative therapy. Now, I can potentially envision ABVD being replaced by an agent like nivolumab, where we're getting durable responses. But you know, I don't primarily treat Hodgkin's, and maybe you have more expertise in that.
I would say that right now we don't have enough data. I agree with you that actually we're talking about responses. The responses were fairly quick, was quite amazing.
They were, yes.
And that's with a single agent. I think we were all pretty much amazed at last year's ASH when the data was coming out. I mean, there's other ones. We just mentioned pembrolizumab from Merck. And with respect to pembrolizumab, which is yet another PD-1 antibody, and I'm not quite sure with respect to, are there any major differences? I guess we'd have to look at where the binding was. Is it just blocking the receptor that the ligand from the tumor is not binding into that receptor? I think there's a whole other area is now we have in solid tumors, the ligand blockade, the anti-PD-L1 antibodies. And the real question is, which one may be better? Would you use, now if you just, the T cell, if you block it, I envision, is there theoretically more of a chance of a renegade T cell going and having more autoimmune disorders? Whereas if you just get to the tumor that has the ligand and you block the ligand, that T cell, when it gets closer, I kind of explain it to patients as a key fitting a lock. The key is blocked, it doesn't fit the lock. So the T cell, it's in the microenvironment, has a better chance of attacking. I think we don't know that yet.
Yeah, but I think that, so the difference is that, that PD-1 actually binds to two ligands, PD-L1 and PD-L2.
Yes, right.
And so, but having said that, you know, there is at least evidence, again, primarily coming out of the solid tumor arena, but I think will be acquired in the liquid side, and certainly with regard to Hodgkin's, that's the case, that PD-L1 expression on the tumor itself appears to correlate as a good biomarker. Certainly,
that's a good point, yeah.
The patients that have high PD-L1 expression are the ones that tend to respond better. I think this has been shown in non-small cell lung cancer, it's been shown in melanoma, and I think there is, you know, one of the points from the Hodgkin's lymphoma is that upregulation of PD-L1 tends to correlate with that. Pembrolizumab and nivolumab, they're showing, again, in the solid tumor arena, pretty similar efficacies. So where one works, the other one works. I think the key, you know, the question, in my opinion, is what is pembrolizumab actually targeting? And it's unclear at this point, you know, what epitope of PD-1 is, it is. And so it, in fact, I think represents a different drug.